Right, I would like to welcome everyone to this afternoon's session on prevention of haemoglobin disorders. I'm Dr. John Old, retired clinical scientist. I've worked on prevention for 40 years, first started in 1974 with Professor Weatherall, and I've collaborated with speakers that you will hear. So I'm sorry, I have problems with his microphone. Maybe he will join us later in the afternoon. Our first speaker then, I'd like to hand over to Mike Angastiliotis. Thank you.
Hello. My presentation is actually to be regarded as an introduction to the talks that are going to follow after mine. It's about prevention, and you may remember that prevention has been mandated. Countries have been encouraged to adopt prevention programs for the last few years, especially where there is a high prevalence and a high incidence of the condition. In a recent study, with nothing to do with the Thalassemia International Federation, the authors actually tried to predict the trend in the number of newborns affected by beta thalassemia over the next few decades, up to 2050. And what you will see is that in the Mediterranean basin, countries of the northern coast, mainly Italy and Greece, that have good prevention programs, the incidence of new births is expected to be level. However, in the eastern coast and in the northern and in the southern coast, there is expected to be a rise, so that overall, in the whole Mediterranean basin, we expect to see a constant rise in new births. When we started many years ago, the disease was a lethal disease of childhood leading to very early death. Resources were scarce in terms of blood and medication. Resources had to be saved for the sake of existing patients. Community awareness was low, but remember that many countries are still in this position today. Now, what's happening nowadays? Optimal treatment leads to increased survival and good quality of life where such treatment is available. There is an expectation of a cure or improved treatment in children that are born today. There have been many cultural changes. In the past, we looked towards premarital screening. Nowadays, couples are living together outside marriage. Consanguinity is getting less and less in urban societies. Still, community awareness is low all over the world. Just to give an example from the media, this young couple actually posted in their plight in the media. They were living together for something like 3 years, very much caring for each other. And just before they considered having children and getting married, they found that they were both carriers. What was their decision? To separate. And they actually posted these to make people aware that this should not be happening. So TIF has been looking at what is happening in various countries. Some of our data and some of the information that I'm going to present has an element of subjectiveness, but it mostly reflects the truth. We looked at about 50 countries with a sizable patient population. We found that in 21 of these, 42%, there is a national plan for screening. However, in these 21 countries, the number of expected births, according to carrier rates and accrued birth rates, should be about 5,500. In the other 19 countries, it will be 10 times as many, over 50,000. So this is an indication that many countries are not preparing themselves. They don't have a national policy. And of course, without a national policy, the likelihood of effective prevention is low. Public awareness. This is a difficult issue to estimate, of course. And with our strict criteria, we found that really adequate effort exists in only about 2 countries. In another 11, there is some moderate effort, and in the rest, either a poor effort or no effort at all. So even where there is a national plan, the information reaching the public is inadequate. Screening. Screening needs to reach practically everyone that's at risk. If counseling is to follow, if choices are to be offered to the people at risk. Screening requires a plan. It requires infrastructure. For example, equipment, personnel, trained personnel, and it needs to be free, out of pocket. Again, we looked at countries and found that effective screening occurred in something like 6 countries. In another 14, it was adequate, but could be done a little bit better. And then in about 30 countries, it was either inadequate or not there at all. So again, screening is not reaching the majority of people at risk. Prenatal diagnosis. This is a choice that can be offered to informed couples. How available is it? Is it free as part of a supported service? Is it available but at a price? There is limited or no availability. And indeed, again, freely offered, we only found 5 countries that actually freely support and offer prenatal diagnosis. In some, another 12, it's offered at a price, it's not free. And in the majority of countries, availability is limited, if not just not available. Counseling. Counseling means providing unbiased information, either to individuals or to couples. Information about their career status, the risk to the offspring, and the various choices that they have. And this information is critical for them to make a proper informed choice. Hardly any country has professional genetic counselors on offer, and in those that do have good genetic counseling, it's offered by the health care professionals of the thalassemia clinics, those who understand hemoglobin disorders. So hemoglobinopathy staff seem to offer in about 7 countries, seem to be the focus of genetic counseling in about 7 countries. In about 10 other countries, we have others which include social workers, obstetricians, and others who are trained a little bit and are aware of hemoglobin disorders. In over 30 countries, either they just get written material or there is no service available and people just either seek help where they can on their own initiative. So if we would, again, this is TIF's assessment. We looked at those countries that we felt had a good chance of reducing the number of annual affected births by about 70%. And we found 6 countries that have such a chance. Good effectiveness, but not sufficient national coordination, but something was being done in another 13. Again, 19 countries out of 50. In many countries, you get either some policies or no national action towards prevention, and therefore we do not expect adequate reduction except for the odd case that actually goes, that's actually wise enough or clever enough to reach services that are very limited. So 38% of affected countries have a program that may reduce birth incidence. In these, 10.9% of the global beta thalassemia births would be born if there was no prevention. Therefore, it's only a minority of births that are actually going to be prevented or reduced in the next few years, quite like the study that I showed before. So countries with a program are a minority of the countries with high prevalence. Births expected, if no prevention, are something like 5,500 in countries that have a program, but over 50,000 or something like 50,000 in countries where there is no such program, and therefore expected to increase over time. So overall, in the globe, in the world, there will be an increase over time. It is interesting, again, that the countries that seem to have programs have a high development index, out of higher income than those countries that do not have a program. Thank you very much.
Okay, thank you, Mike. Lovely delivery. I would like to thank the audience for question. The presenter that you want to ask the question to. A colleague of mine worked many years, and we actually described the prenatal diagnosis in the first trimester in 1981. Great pleasure that I invite you to listen to talking about challenges in implementing national prevention programs. Thank you, Mary.
Hello, I'm Mary Petru. I'm head of the Haemoglobinopathy Genetics and Prevention unit at UCL in London. Today I'm going to talk about some of the barriers in implementing effective prevention programs. Now, 15 years ago, WHO urged member states to design, implement in an effective manner integrated programs for prevention and the management of haemoglobinopathies, including surveillance, dissemination of information, awareness raising, screening, and such programs being tailored to specific countries. Now, we have over 40 years of experience of how people and health systems use prevention programs for haemoglobinopathies. We know the global distribution. They exist in high, middle, and low income countries. The carrier detection is sensitive and specific, and it's cheap. We can test partners. We can provide definitive reproductive risk information, and the options for risk reduction are available. Where are we with service delivery? Well, to have an optimal prevention program, it needs to be a national program. So you need all these components. You need your epidemiology, you need your screening strategy, you need your screening laboratories, you need your genetic counseling, your prenatal diagnosis laboratory, your fetal medicine units, and PGD if it's available. You need your education for both the public and the health professionals, and you need to audit your program to see how it's performing. Now, let's look at carrier screening. Now, in most Western countries, the consensus is that the aim of carrier screening should be to enhance reproductive autonomy and enable meaningful reproductive choices. However, from the global perspective, there are different views. In some communities with a high burden of severe disease, population-level prevention is regarded as the appropriate aim of carrier screening. And in those cases, reduced birth rates of affected children may be regarded as the measure of success. Now let's look at or remind ourselves of the core ethical principles of genetic counseling, where it's the right to full and accurate information, the autonomy of the individual or couple, i.e. informed choice, and strict confidentiality. Now, screening can be performed at different life stages. Now, if we look at the Mediterranean area, they have opted for premarital screening because it permits the informed choice amongst all these options here. And they also have the option of separating and their partner choice. However, it's limited to unmarried couples, and it takes over 20 years to have full effect if married couples are not included. So you need to include married couples, maybe by also including antenatal screening. Now there's preconception screening, which targets all couples planning a pregnancy, but the options are reduced. They can restrict family size or prenatal diagnosis or termination termination of pregnancy, and there's the option of neonatal diagnosis. Now in the UK we have antenatal screening, and so the option with antenatal screening is prenatal diagnosis or not, or neonatal diagnosis. Now it's only ethical, of course, if prenatal diagnosis is available with the option of TOP. Now what we have found is that the risk is often detected too late for the option of prenatal, or some couples are detected so late they feel it's just too late for them to go ahead with prenatal diagnosis. Now, in the Mediterranean area, as we said earlier, premarital screening is a chosen policy. Now, the Cyprus program is based on mandatory premarital screening with genetic counseling and the offer of prenatal diagnosis. And most couples do go ahead and marry. And there's been a major reduction in the birth prevalence of thalassemia major. Consequently, their results are often taken to model the effects of premarital screening. Now, let's look at premarital screening alone. This may be the chosen policy in countries where termination is not available. And so the couple have the option of separating. But does this actually happen, and what are the consequences? So the implied assumption is that identification of these at-risk couples, that they will separate. And it's often proposed that earlier screening might have a stronger effect on partner choice, especially in societies where marriages are arranged. However, the acceptability may be limited, as disclosure of carrier status prior to marriage can lead to breakdown of planned marriages that actually are not at risk. And there is a risk that another partner will be a carrier. And we haven't seen any follow-up studies on what happens to individuals where marriage arrangements have been broken, what happens to their esteem and marriage chances. There are cultural and social factors that may be taken into account, and pre-pregnancy testing may be a more desirable option. Now, what's happened in Saudi Arabia? Now, in 2003, they implemented a mandatory premarital screening program for sickle cell and thalassemia. Their main goal was to decrease the incidence of sickle cell and thalassemia by elimination or significantly decreasing the number of high-risk couples marrying. What they found initially was 90% of at-risk couples actually proceeded to marry. So their conclusions were here. They didn't think they were successful in achieving their main goal. And to improve this outcome, they recommended intensification of the counseling mechanism for these couples. Now we have to remember the counselors in Saudi Arabia working within the context where prenatal diagnosis and termination of pregnancy is not available. So they're working in a different framework. Now, later data shows that 50% of couples separate when they are provided with incompatible certificates and genetic counseling. Now, this study here looked at 3 groups in Saudi Arabia: the general population, couples presenting for premarital screening, and couples who had received their results. In general, most agreed that premarital screening should be offered. Now, groups A and B, 66% of them said at-risk couples should not be allowed to marry. However, they found that over 86% of at-risk couples, i.e. this group C here, when they received their results, actually did proceed to marry, showing that what couples actually think they're going to do is different to what they actually do when faced with the actual results. And we've seen this in other studies earlier on. Now, how about the Iranian prevention program? Well, they implemented a prevention program very similar to the Saudi program, as termination of pregnancy was not allowed. So their goal was that couples should separate. There was an escalating number of patients in Iran and a demand of care. There was a demand for care, and the affected families started asking for prevention. Now, in 1997, they looked at their data. Now, at that stage, prenatal diagnosis was not part of the national program, and it was available only on a private basis in 1 or 2 centers. They found that over 50% of couples actually married, less than 30% separated, about 30% separated, and the remainder at that time were undecided. Now, when they looked at the data later on, they followed up 75% of the at-risk couples. They found the separation rate was less than 10%, with most couples using prenatal diagnosis and most terminating affected pregnancies. How did they overcome their barriers of prenatal diagnosis? Religion? Well, they consulted with the religious scholars, and they obtained a religious decree from the major leaders permitting termination of pregnancy up to 120 days for a severe genetic abnormality. They implemented ethical genetic counseling with informed choice, and in 2003 they overcome the barrier of the finance, because most of the P&D costs are covered by an insurance system. Likewise, in Pakistan, with this Dr. Suhaib Ahmed also consulted with religious leaders and obtained a fatwa permitting termination of pregnancy up to 120 days. Now, there's no national prevention program in Pakistan, although there is a regional program in the Punjab offering premarital screening. Now, also in Pakistan, this study showed that the 4 main factors why women did not have prenatal diagnosis was actually not knowing about it, the high cost of the test, the lack of access to a center offering prenatal, and also the delay in actually requesting a test. Now, this study here looked at couples who had affected children with thalassemia major. They discussed with them the availability of prenatal diagnosis and the option of terminating an affected pregnancy. also discussed the fatwa permitting termination for severe disorders up to 120 days. The prenatal diagnosis and termination of pregnancy would be provided free of charge. And as a result, all the couples planning to have more children plan to request testing in every pregnancy in the future. And follow-up studies showed that they actually did request prenatal testing. Now, let's look at Bangladesh. In Bangladesh, there's no national prevention program, no screening program. There is a couple of centers that offer prenatal diagnosis. Now, in Bangladesh, 70% of the population reside in resource-limited rural areas with very few facilities. About 6 to 12% of the population are carriers of beta thalassemia and hemoglobin E, and up to 40% of hemoglobin E in the tribal areas. Around 60 to 70,000 children are affected with hemoglobinopathies in Bangladesh, and we estimate around 10,000 children born per year. And there's very few specialized thalassemia centers, and most are in the capital, Dhaka. Now, this study looked at these parents with affected children. They found that 80% of them faced difficulty in obtaining blood donors regularly, and 40% of them felt socially stigmatized. Now, 35% of them had heard of prenatal diagnosis, and 25% of parents would consider prenatal diagnosis in a future pregnancy. 70% were unsure because it was such a new concept for them. And very interestingly, only 5% would decline prenatal diagnosis in a future pregnancy. 21% said they would consider terminating an affected pregnancy, but again, interestingly, only 6.6% would decline a termination, and the remainder were unsure. We have to remember that Bangladesh is a country with a devout Islamic country. Now, when asked about premarital screening, what would they do if it was available? Most said they would not have married if they understood the risk. But again, we don't know what they would have done if they were actually faced with the results in practice. Now, nearly all parents had never heard of thalassemia before their child's diagnosis. So the conclusion was obviously poor parental knowledge regarding thalassemia, and the awareness of thalassemia should be in the forefront in the development of prevention strategies in Bangladesh. And in summary, what are the challenges in implementing ethical prevention programs? Well, you need to know your epidemiology, and we've got quite good global data. There needs to be a political will and commitment. You have to have the resources, the finance. There needs to be the infrastructure, guidelines and protocols, religion. The countries have involved religions, which I've showed you in 2 countries, but also remember Cyprus also involved the religious leaders. There has to be training and education for professionals and the public, and public health should take the lead. Now, we know there's often a lack of a collective sense of urgency of genetic screening, and because health services tend to focus on traditional public health interventions, such as smoking and alcohol in pregnancy, instead of discussing genetic risks. Thank you.
Hello? Shall I talk to Mary?
Yes, yeah. Thank you.
Yes.
Thank you, Mary Petru. To a couple of, I don't know whether to introduce our next speaker. Is that possible?
This I would
No.
also to be. In fact, I have heard with a lot of interest, Mary's report. It's very useful to review the whole question in that way. And I would like to, the way she presented that shows that in many countries, prenatal, by screening, population screening, and other well accepted. For the large surveys, the large populations, one needs simple and non-expensive techniques. And of course, all nations who are implementing have established theories which offer this possibility. Hello.
Okay,
Something goes wrong.
move on then. Our third speaker, Sopalu, is going to in population screening for hemoglobin disorders. Thank you.
Good afternoon from Athens. I would like to thank the organizers of the 15th International Conference on Thalassemia and Other Hemoglobinopathies for inviting me to participate in this conference, giving the presentation entitled Potential Sources of Error in Population Screening for Hemoglobin Disorders. Prevention starts with carrier identification. This is a crucial step aiming to identify out of a general population the carriers of inherited hemoglobin disorders and to guide them across the measures which may allow avoiding the birth of children with hemoglobinopathy. The diagnostic procedures, be they simple or complex, do not allow any errors, not only because the result is catastrophic for the couplet risk, but also because an error may blur the confidence of the involved population in the procedure. For the greatest majority of cases, the diagnostic procedures have the advantage that they can be carried out in a few milliliters of anticoagulated blood. Routine studies can identify more than 95% of the heterozygote carriers of the noxious genes. The remaining 5% requires more sophisticated techniques. Embarking on a large-scale prevention program requires complete laboratory support in the form of a comprehensive center or a well-organized network. For the large majority of cases, the diagnosis of heterozygote thalassemia relies on a set of basic parameters which can be easily measured on a blood sample of the examinee. The respective techniques are simple, easy to perform, fast, and non-expensive. Basic criteria are listed further below. For beta thalassemia, low MCH and less specifically MCV, along with abnormal RBC morphology and elevated hemoglobin A2. For alpha thalassemia, low MCH and less specifically MCV, along with abnormal RBC morphology and normal hemoglobin A2. An auxiliary method used mostly in the past is the hemoglobin biosynthesis. Beta to A ratio lower than 0.7 denote for beta thalassemia, while beta to A ratio higher than 0.7 denote for alpha thalassemia. Algorithms using the above data towards the diagnosis of a thalassemia trait have been repeatedly published and validated. The comprehensive report produced by a group of experts in 2014 reflects satisfactorily the official guidelines. Evidently, differentiating thalassemia carriers from normal individuals requires the establishment of normal values. Ideally, normal values for each parameter should be established by large surveys across each population. However, this has been neglected over the recent years because neither parameter displays a neat border between normal and abnormal values, while small intralaboratory differences blur the value of such studies. Today, the general agreement, backed by various official guidelines, is that the lower cutoff limit of normal MCH must be above 27 picogram, and the upper limit for normal hemoglobin A2 no more than 3%. The limits defined by these values cover more than 95% of the carrier population. The remaining 5% includes persons with atypical features, which may be erroneously interpreted and lead to catastrophic results in the sense of either diagnosing a thalassemia trait in cases where this is not true, or defining a heterozygous state in cases that the examinee is normal. Such atypical cases have been reported from all parts of the world and are not uncommon in the Mediterranean and the Middle East countries. So the goal of this communication is to present a didactic classification of the most prominent atypical cases and propose algorithms for their investigation. The most prominent atypical cases are grouped as follows. First, beta thalassemia carriers with slightly decreased to normal MCH, normal RBC morphology, and slightly elevated to normal hemoglobin A2. Second, beta thalassemia carriers with decreased MCH, abnormal RBC morphology, and low to normal hemoglobin A2. Third, beta thalassemia carriers with normal MCH, normal RBC morphology, normal hemoglobin A2, and varying amounts of hemoglobin F. Fourth, beta thalassemia carriers with co-inheritance of triplicated alpha genes. And finally, fifth, alpha thalassemia carriers with slightly decreased to normal MCH, abnormal to normal RBC morphology, and low to normal hemoglobin A2. Going to the details, the first group includes beta thalassemia carriers with normal or slightly decreased MCH, normal RBC morphology, and marginally elevated hemoglobin A2. Here belong a number of mild and silent mutations at the beta gene promoter sequences, such as the -101 C2T mutation, which displays borderline values in the heterozygote state and results in thalassemia intermedia when co-inherited with a typical beta thalassemia trait. This group also comprises other mutations in the 5' and 3' untranslated regions or in the intervening sequences of the beta gene as listed below in red. Especially the CAP+5070 T2C variation has proven recently to be pathogenic when combined with specific beta-0 thalassemic mutations. In addition, this group includes the heterozygote state of alpha gene triplications that exhibit frequencies between 1 to 5% in different populations. Of importance is that frequency of these mutations can be underestimated because many carriers exhibit quite asymptomatic. The second group involves beta thalassemia carriers with decreased MCH, abnormal RBC morphology, and low to normal hemoglobin A2. Most of these cases involve the coexistence of beta and delta thalassemia mutations, either in trans or in cis. Typical examples of the in cis pattern of inheritance are the beta mutations, IDS1 5G2A, the Corfu deletion, and hemoglobin knossos. Large deletions, also beta cluster involving the delta gene, accompanied by elevated hemoglobin F levels, are included in this group. Of course, iron deficiency must be excluded, given that the decreased quantity of heme results in poor hemoglobinization of the red cells. Moreover, the second group includes cases of co-inheritance of alpha and beta thalassemia. Co-inheritance of alpha and beta thalassemia is not uncommon in countries where both traits exhibit high prevalence and constitutes a challenge for the respective screening programs. This co-inheritance may slightly modify the CBC, mainly MCV, and hemoglobin A2 parameters in beta thalassemia carriers, so that usually an alpha thalassemia trait is masked by beta thalassemia. Therefore, a definite characterization for both traits in couples at risk for beta thalassemia is critical. Consequently, for proper genetic counseling referring to beta thalassemia syndromes, hemoglobinopathy H, and hemoglobinopathy Bart's hydrops vitalis, complete screening for both alpha and beta mutations is highly recommended in couples of beta carriers. The third group includes beta thalassemia carriers with normal MCH, normal RBC morphology, normal to decreased hemoglobin A2, and varying amounts of hemoglobin F. Normal values of hemoglobin F in adults do not exceed 2%. However, these values may be higher in the following conditions: presence of different types of hereditary persistence of fetal hemoglobin, HPFH, pancellular or heterocellular forms, deletional or non-deletional, or presence of variations in quantitative trait loci like XMN1 polymorphism, or variations in other genes like BCL11, A, KLF1, etc., or to other conditions such as pregnancy, certain types of malignancies, aplastic anemia, etc. According to the literature, hemoglobin F values ranging up to 5% denote the presence of variations in quantitative trait loci and do not need any further action. On the contrary, values of hemoglobin F higher than 5% are compatible with the presence of deletional or non-deletional forms of HPFH. As the various combinations of HPFH with beta thalassemia mutations may result in thalassemia intermedia, such cases need further investigation. The fourth group includes beta thalassemia carriers with co-inheritance of triplicated alpha genes. Co-inheritance of beta gene mutations with triplicated alpha genes gives rise to different thalassemia phenotypes, ranging from a typical thalassemia trait to thalassemia intermediate. The clinical feature of the above genotype depend on the specific beta thalassemia mutation. Finally, the fifth group includes alpha thalassemia carriers with slightly decreased to normal MCH, have normal RBC morphology, and flow to normal hemoglobin A2. Here belong, first, the minus alpha 3.7 deletion, which is the most frequent alpha thalassemia mutation worldwide and presents as a mild or even completely silent mutation when in heterozygous state. And certain unstable hemoglobins like hemoglobin TB or hemoglobin adana that may present quite asymptomatic in heterozygosity, but when associated with alpha globin gene defects, even with minus alpha 3.5 deletion, give rise to hemoglobinopathy H disease. Concluding remarks. The list of atypical cases of thalassemia mutations reported in the previous slides does not stop here, because there still remain various nucleotide changes across the regulatory sequences of the globin genes, which may decrease mildly their expression, but cannot be recognized because the deficit is readily compensated through other mechanisms. The fact that these mechanisms are functioning not only within the globin complex, but can also be influenced by external modifying factors, makes their understanding extremely difficult. The phenotype of these minor changes is very mild indeed. In many instances, it does not differ from normal, while in others is atypical, displaying minimally or not at all the thalassemic features already mentioned. In most cases, these defects are recognized when their allelic genes happen to be thalassemic and cannot compensate for the deficit, so that the end result is an offspring with a very mild thalassemic picture who finally seeks medical attention. Thank you very much for your attention.
Right, I would like to
Yes.
talk a little in presentation. These atypical cases are very important and in laboratories. And I'd like to put a plug in for the book for prevention of free of charge, get it from and a lot of points covered in the book. We now move on to the last, Dr. Jan Traeger-Sinodinis, another an Oxford, who's going to teach us about laboratory approaches for hemoglobin disorders. Over to you, Jan.
Since this talk is pre-recorded, and I'm not sure what time it is where you're all following, I'll simply say hello to everybody. And before I talk, I'd like to thank the organisers of the meeting for inviting me to give this talk in this conference today. And I was asked to talk about new laboratory approaches for hemoglobin disorders, and I will do so in the context of prevention. Now, the hemoglobinopathies are grouped according to which globin polypeptide chain is, or which polypeptide chains are defectively synthesized. When we have reduced production of globin chains, we have thalassemias, and when we have altered structure in a globin chain, then we have a hemoglobin variant. Now, there are over 300 clinically significant variants that have been described associated with the hemoglobinopathies. For the beta globinopathies, which include beta thalassemia and structural variants like hemoglobin S and hemoglobin E, we're talking mainly about nucleotide variants, or otherwise known as point mutations, within the beta globin gene or its immediate flanking regions. For the alpha thalassemias and the delta beta thalassemias, we're talking mainly about deletions of the specific globin gene or genes, or deletions from the gene clusters, respectively. So traditionally, each population has a unique combination of abnormal hemoglobins and thalassemia disorders, and this means that the spectrum of variants and their frequencies are also population specific. Usually there is a limited number of common variants and perhaps a slightly larger number of rare variants, and maybe in some populations you have 10, 15 or up to 20 different variants that are often found. Now, the knowledge of the ethnic origin and family history of a patient may support the diagnostic strategy towards the definitive identification of the underlying genotypes, but with the advent of global migration, this strategy has become less relevant. Now, this slide summarizes the clinically relevant hemoglobinopathies that we will probably want to target in a prevention program. So we have the beta globinopathies that include thalassemia major and intermedia, the sickle cell syndromes and hemoglobin E thalassemia, and the alpha globinopathies that involve hemoglobinopathy H or hemoglobin H disease and hemoglobin Bart's hydrops fetalis. Now, laboratory methods have a fundamental role in the diagnosis of hemoglobinopathies, as with all genetic disorders, in fact. With respect to carrier detection and for definitive diagnosis of patients, laboratory approaches are an essential adjunct to either hematology and or clinical symptomology. But since this talk is in the context of prevention, I will focus mainly on carrier detection. So laboratory approaches for carrier screening involve two parallel approaches that are both essential to the process. So we can have hematology and biochemical analysis, and this allows a presumptive diagnosis in most cases, or we can have DNA analysis, which supports a definitive diagnosis in most cases. When performing a carrier screening strategy, it's probably much better that hematology precedes the DNA analysis, because the hematological parameters that are identified are essential really to direct the most appropriate DNA analysis in the laboratory, the best methods, and also to evaluate the result from the DNA analysis. And the findings from the hematology and the biochemical analysis and the DNA analysis should all be concordant for us to be happy that we've actually got a definitive diagnosis of the hemoglobinopathy in that particular patient. Now, this is a little bit of a busy slide, but it summarizes the general strategies for carrier screening, which include first-line hematology testing for the red cell indices and the hemoglobin quantification and identification and quantification, and then sometimes second-line hematology tests can be performed, red cell morphology, osmotic fragility, sickling test, etc. But I must say that in my experience, these tests are getting less and less commonly used. And finally, once we're happy with the hematology, we go on to select the most appropriate method for the DNA analysis to find the genotype. So looking at the hematology, and I'm talking about the methodology essentially, complete blood count is achieved basically using automated instrumentation these days. Everyone must have an automatic instrument to do this, I would say in most labs worldwide. For the hemoglobin pattern and the hemoglobin quantification, again, most laboratories will probably have access to either an HPLC system or a capillary electrophoresis system, or both. Newer methods like mass spectrometry offer great potential, but the instrumentation is very expensive, and this method has never been widely adopted. Now, without going into too much detail, this slide is an overview of the algorithm that one can use in order to select the most appropriate methods for the DNA analysis. So with the thalassemias, we will have reduced red cell indices, and sometimes we get no abnormal hemoglobin fractions or quantification, so that we would probably suspect alpha thalassemia. So we go for alpha thalassemia deletion analysis firstly, and then point mutation analysis less commonly. For the beta thalassemias with reduced red cell indices and a raised hemoglobin A2, we'd look firstly for a point mutation within the beta globin genes, or a deletion, which is much rarer, of course. When we have an abnormal fraction with hemoglobin separation and quantification, with or without red cell indices, often without, we would look for, by sequencing, variants in either the alpha globin genes or the beta globin gene. And then if we have raised levels of hemoglobin F and normal levels of hemoglobin A2 with reduced indices, we might expect a delta beta thalassemia deletion. Now, as for the methods that we can use, there are many different PCR-based techniques. And still most current methods are based on the PCR. The PCR method being developed in the middle of the 1980s. And once we discovered the PCR reaction, or once it was discovered by Kerry Mullis and co-workers, there was an explosion of methodologies for investigating the presence or absence of specific variants within genes. And a lot of the methods that were designed were based on the beta and alpha globin genes as a model, essentially. So we can have various methods. I've listed a few: restriction endonuclease analysis of PCR products, allele-specific PCR, allele-specific oligonucleotide or ASO hybridization to PCR products. And these are all methods and many more for seeing if there's a single nucleotide variant within a sample or present or absent. And for known deletions, we can apply gap PCR, which is simply targeted PCRs that are designed to amplify across a deletion breakpoint if it exists in a sample. Put very simply, that is. Now, all of these methods for DNA analysis that are targeted are simple, with low running costs and equipment costs. They don't need sophisticated equipment really, other than a PCR machine and perhaps a gel electrophoresis equipment. They're relatively quick if we're looking at a small range of variants and a small number of samples, and they're extremely reliable if the procedures are well validated. The limitations, however, is that they're low throughput when screening lots of different variants and or lots of samples, and this can be a bottleneck when, for example, characterizing parental variants in an ongoing pregnancy. They're not practical for populations with a large spectrum of variants, and they're not practical in geographical regions where the trend of population migration has broadened the spectrum of variants that we find. So one approach that has been adopted in at least those labs that have access to an automatic sequencer is to perform Sanger sequencing across the globin genes to detect any nucleotide variant within the genes, or along with multiplex ligation dependent probe amplification, otherwise known as MLPA, that can detect any deletions or duplications across the targeted gene region. Now, there's always been a constant attempt to develop new methods that will allow higher throughput and automation for detecting nucleotide variants. Real-time PCR, Paris sequencing, high-resolution melting analysis are a few of those that have been tried. And for large deletions and insertions, array comparative genome hybridization of the globin genes has been attempted too. But none of these methods have ever been widely adopted because they require expensive equipment. They often have high running costs, and they essentially have no advantages over the generic approach of using Sanger sequencing with MLPA on an automatic sequencer. But having said that, of course, we're now in the era of next generation sequencing or massively parallel sequencing. And this approach has great potential. It can be genome-wide or relatively targeted, and it allows the simultaneous analysis of huge regions of the genome in a single analytical procedure. Now, for the hemoglobinopathies specifically, there are certain technical challenges with using NGS for sequencing the globin genes. Firstly, we have high homology between the globin genes, so this requires custom-made approaches for library preparation, and also the homology between the genes means that you probably need to modify your bioinformatics for read mapping. The protocols, of course, can be modified to detect deletions as well as nucleotide variants, which is an advantage. But there have been quite a few reports of successful application of customized NGS protocols, and I'll just go through a couple of them in the next couple of. So this slide summarizes a couple of examples of the use of a machine called the Ion Torrent PGM, which is a medium throughput NGS machine. And the first study was probably the first that was published. It came out of the group from Leiden, that demonstrated that the machine could be used for rapid sequencing of the beta globin gene in a large number of samples. And the second study came out of China more recently, which also said that it was excellent and showed high accuracy and repeatability. But on the whole, the papers tend to conclude that for routine use, we still have to consider validation of this approach. Now, there are also some commercial kits out there that allow NGS for the haemoglobinopathies. I know of one. I won't mention the actual kit itself. This isn't relevant right now, but I just want to use it to illustrate some of the advantages and limitations of using such approaches. So one kit says that it does a one-tube NGS assay to detect all variants in the globin genes and also deletion variants and insertions across the globin gene clusters. And this sort of illustrates the strategies that these kits tend to use. We have in blue the actual globin genes that are sequenced from end to end to identify single nucleotide variants that underlie the either beta thalassemia or alpha thalassemia or hemoglobin variant that we're interested in identifying. And then across the clusters of both the alpha globin genes and the beta globin genes, primers can be designed to amplify regions that are sequenced, and then there's a semi-quantitative evaluation of each fragment so that we can understand if there's deletions or duplications of regions across of each of the genomes, a bit like MLPA in a way, but using sequencing rather than ligation of probes. So this is just an illustration of a sample in which across the beta globin gene cluster there were no deletions or insertions detected, but in the alpha thalassemia, in the alpha globin gene cluster, this particular sample had both an alpha 3.7 and an alpha 4.2 deletion. It was a compound heterozygote charistate, and it had two functioning alpha globin genes, of course. I used this kit ourselves in the lab, and we found that for identifying variants in the beta globin gene, it was superb. It detected the variants very efficiently with very high accuracy. But for the alpha globin genes, we found that the method wasn't able to allocate which alpha globin gene had the variant if one was identified, which can be a disadvantage when we're doing definitive diagnosis of carriers and indicates that we will probably require an additional method to define which alpha globin gene the variant was in. And with respect to deletions, we found that there were difficulties in defining deletions in samples which were compound heterozygous for certain deletions and or duplications. And this led to a rejection of the sample for analysis, which meant that we didn't get a result. And overall, these methods tend to be rather costly still per sample, which is a major limitation for their wider uptake, especially since we probably will still need to use ancillary tests for genotyping certain regions. So, although NGS has great potential, I would like to make a note of caution when using NGS. Although, as I say, it's an excellent method, it is not a standalone method. I have seen quite a few papers. I reviewed quite a few of them in the earlier days when NGS was being first introduced for diagnosing diseases. And yes, NGS can detect any variant within a region that you've targeted, but you have to make sure that that variant actually causes some sort of pathology and is not a benign variant. Therefore, the hematology should always be used alongside the genotyping, even if you use NGS as your method. Of course, NGS for identifying patient genotypes is extremely advantageous potentially. Besides being able to detect any variant within the globin gene clusters, one perhaps can also design panels to genotype any other genes that have been or will be associated with modifying the clinical expression of a hemoglobinopathy patient or patients. and also the genotypes and genes involved in response to drug treatment and alloimmunization. So, closing remarks on newer hematology methods. For carrier screening, the need to evaluate a wide range of hematological and biochemical parameters is unlikely to change. Current methods are reliable. It's difficult to foresee many or any improvements, perhaps, in the actual laboratory procedures. Possibly only the price of some automated equipment could drop, making more automated technologies available to communities and/or countries with limited resources. So the closing remarks on newer genotyping methods. I would say that the targeted methods of or a generic combination of Sanger sequencing with MLPA are adequate in most settings today. Newer methods still have limitations. They require specialized equipment with usually a high purchase cost initially, although sample analysis may be cost effective in the long term. They also require method standardization and sample processing and data interpretation, all of which can be technically demanding. And this means that they require highly trained operators. No single method, in fact, yet fulfills the ideal criteria, which would be a universal, rapid, reliable, automated, and inexpensive method. But it's likely that this is never going to be a possibility, because the molecular genetics of the hemoglobinopathies will always likely require a range of methods. Selecting the right method for a carrier screening program means that one has to evaluate the carrier rate in the population and the types of hemoglobinopathies that are present, the laboratory infrastructure, and multi-ethnic screening will require a wide battery of methods, especially for DNA analysis. The expertise of the laboratory staff has to be considered, as well as the budget. But whatever the method that is selected, quality control for all laboratory methods is fundamental. There are some guidelines that were published in 2014 by the EMQN, which are extremely relevant still today for nearly all the methods that we will be using, as well as the guidelines by ANERCA. Also, there are some very valuable publications by TIFF describing laboratory methods for thalassemia diagnosis and other hemoglobinopathy disorders as well. And I would like to thank you for your attention.
Very informative talk. I believe we're now open for questions. Is that correct?
Okay.
Αυτό δεν χρειάζεται.
Ah, there we are. It's on the
Question.
There are no questions.
I yeah. I think so. Describe as a DNA plasma, and yet in pregnancy. Do you foresee that will use of cell-free DNA?
For DNA. Can you not hear me? Hello?
Yes, go ahead.
Yeah, can you hear me now? Yes, okay.
Close my.
Thank you
Okay.
for the question. Thank you for the question. Yes, I think it's a question of depth of sequencing. If you sequence deep enough in the cell-free DNA, you will be able to detect and quantify, relatively speaking, both the parental variants, using also algorithms to evaluate the read depth relative, because the paternal mutation, if it's different from the mother's, that's quite easy to pick up. But relative to the mother's mutation, and that the fetal will or will not have inherited from her, you have to do it quantitatively as well. And for best practice, it's probably a good idea to be able to do the parental haplotypes as well. So you're looking at more than one variant to derive the diagnosis. But I would say potentially it's possible, but as many of these newer technologies are, it's a question of the cost for the equipment and also for the running costs of the sample. And the one big disadvantage with next generation sequencing is that for it to be cost effective, you have to do high throughput sample analysis, which means that you never will have enough prenatal diagnosis simultaneously in order to justify running most of your samples on an NGS machine a lot of the time, and certainly not in countries with limited resources. Are you still there, John?
Yeah, that's very interesting. Yes, I'm still here. UK NECWAS, we send out samples to 50 countries.
Right.
Countries using NGS. Every other country is using the standard methods that you described. Some, going back 20 odd years, and they're still used, work, and they're cheap and they're reliable. So
yeah,
it points to the NGS really hasn't place in screening laboratory.
No, I think it's a question of cost. I mean, if every country had the possibility perhaps of having a core lab where all the samples would be run centrally, then that would make it perhaps potentially cost effective, and yes, it could be a method. I have noticed that in China, for example, they do tend to use NGS even for carrier screening fairly routinely. But I guess maybe there's a slightly different setup for their health providing systems.
Can I follow on from that question?
Yeah, I'm sure it is a different setup.
Can you hear me?
Yes, Mary, I can.
Yes.
I wondered what you thought about expanded carrier screening using NGS, and is that going to come in the future, i.e. Screening for more than thalassemia? Because that's what we're thinking about now.
Okay, do you want me to answer this one as well?
Sorry?
This question is directed to me again.
To you, yes. Yeah.
Yes. Well, I think again that's a very good question, Mary. I think the problem with expanded carrier screening and the hemoglobinopathies is that it's fairly straightforward to do expanded carrier screening for a lot of genes that are associated with disorders like CFTR, and you can do Duchenne muscular dystrophy and a whole load of other. The panels can be variously limited to maybe 100 and 150 genes or diseases, and I've seen protocols that go up to 500 and 700, and that's fine. But there is a big limitation with using expanded carrier screening for the alpha thalassemias, because you need a different methodological approach. Like I said, that you need to do a selective library preparation that's targeted for the globin genes, because of the fact that they've got lots of homology. I mean, not so much with beta and delta, but even there you will have to be careful. But certainly with the 2 alpha globin genes, you will have to do a specific library prep, which means that you can't really use the standard carrier screening approaches that are commercially available, or even design one easily yourself, that would be validated to include the hemoglobin globin gene. So in theory, yes, again, but it's a question of cost effectiveness. And also here, the limitations of the technology of NGS actually don't really fit very well with the globin genes alongside other standard genes that you just need to screen the sequence of the exons from length to length, and that's it. The molecular genetics of the hemoglobinopathies are much more complicated and don't really allow them to be used for NGS, even within the context of expanded carrier screening. I don't know, does anybody else? Yeah, Angeliki, do you have an opinion?
I have no experience because in our lab we use only the conventional methods, and I think it's quite expensive for right now, especially in our country, to apply this. But the larger problem is what you already mentioned, that the homologies between among the different thalassemia genes constitutes a problem in order to discriminate if it's a delta or beta mutation. And this is a great problem in the context of genetic counseling. So you should have a very well-experienced personnel and well-experienced not only technical, all over hemoglobinopathies to give the right results. I don't think that this time, right now, we can apply in a mass screening program, next generation sequencing.
Yeah, I will agree with you completely.
Can I make a comment here? There's quite a lot of commercial companies offering screening for hemoglobinopathies using NGS. And, I worry about these results because we have patients who come to the hospital and they say, I've been screened for thalassemia and sickle cell, and they produce these results by NGS from some company that we've never heard of. And they refuse to be tested again, particularly partners of women. And so, it is a worry because we don't know how they've been validated or, confirmed.
Yeah, yes, I think we should be worried. I think some of the companies are aware of the limitations of their methods and have them summarized in small print somewhere in the answer. But they are screening methods, and they screen for a percentage of, the low-hanging fruit, if you like, relative to the molecular variants that we might expect. They will definitely not give you a comprehensive screening result. And this is very dangerous because if they don't look at the hematology as well, then a lot of carriers will be missed or mischaracterized as well. Yeah, I think we do have to be very worried. There are lots of American companies that I know of that I've seen some of their panels and their brochures, and they seem to be completely unaware of the fact that certainly with hemoglobinopathies, the tremendous molecular genetic variation is a big limitation, and they have to be very careful with the way they offer these tests, because people pay for them because they're usually not covered by health systems, and they may actually get a wrong diagnosis. Have we lost John, or is he there?
Yeah, I think that's a very good. No, my picture's gone for some reason. It's fading in and out. So, but I'm still here. Question for Mike. Tiff, your presentation seems to suggest that it's out of the ball really with prevention and don't seem to have got very. Yes, it's going to come in. Shouldn't Tiff now be thinking more about for the first screening programs.
I think TIF should be encouraging simple. Sorry, can you hear me? Yeah. I think, John, what TIF should be encouraging are not new generation sequencing or any kind of exotic kind of laboratory techniques. What TIF should be doing is encouraging awareness, encouraging governments to take an interest, and promoting some kind of acceptable policies to their population. Trying to understand what the population will consider and what the population would respond to. The difficulties with laboratory issues will always be there. How they're going to be solved is another issue. TIF is more concerned with basic laboratory stuff, but also with it's the importance of knowledge, community knowledge, staff training, etc.
Yeah, no, I couldn't. It's all about interpreting genotypes with phenotypes. The expert in the laboratory, we try and push that for the UK. But I would think treatment, gene therapies, considerations. To keep promoting. I think. Any more questions? Without any main questions, end the session now.
Can I ask a question to Mike, please? Can you hear me, Mike? I can't hear you.
Sorry, Mary. Loud and clear. I can hear you. Yes.
Okay. Mike, I wondered what you thought about how do we measure prevention programs? Because we often hear, about success rates. Is that how we should be measuring these programs? Or should we be thinking success rate is providing informed choice?
Of course, informed choice is extremely important. But when you're living in an area, you've got to take a global view. When you're living in countries where the maximum age of thalassemia patients is 16 and 20, the average age is about 10 or 11. It's informed choice is one issue, but at the same time, you need to save resources. You need to reduce the number of affected births. The era of sophisticated issues like the patients, the couple should choose is good. It should be available. Free choice and informed choice should be available to everybody, but you still need to reduce the number of births in the majority of countries in the world. Let me give you one example of one country where the health authorities realized that thalassemia is number 5 in the most catastrophic diseases in the health service. You can't expect that country not to consider prevention as a whole, not to consider reduction of birth incidence as an important issue.
Well, I agree with you. I mean, I can speak on, for Bangladesh because I've been involved with Bangladesh for the last few years. And it's just now, I mean, they definitely need a prevention program. And it's just now they're beginning to think about it, how we're going to do it.
Michelle Abi Said, I don't know if you can see it. if you can't.
A comment from
She's
Michelle.
Oh, okay.
Yes, it's just come up on my screen. Yeah, she says excellent press. Any on a team that's under development to give similar results to HPLC. Do you know what she's talking about? I have no idea.
I think she's talking
A new
about
machine
point of
HPLC.
yeah, it's point of care devices. There are a few on the market where you visit a village perhaps, or have a few people and you've got something at the bedside with which you can identify a variant. They're interesting, but for large-scale screening, they're not very practical, obviously.
Okay.
There's also
Well, can you see it? I can't see it.
yeah.
Oh, hang on. Yes,
George
just
is
appeared.
asking-
It's from George.
Yeah.
Can you read that?
Yeah. Oh, okay. Yeah. Can you evaluate
How
the
is
council
it's unbiased?
is unbiased?
Not possible.
You know, counseling takes place within closed doors between a counsellor or whoever that counsellor may be and an involved couple or an individual. What they say between them is totally impossible to evaluate as far as I can see. And very often we know that they are biased.
Okay. Okay.
Well,
That have come up on my. I'd like to thank the presenters for your excellent contributions. See some of you in person eventually.
Yeah, that will be good.
That would be lovely.
Thank you, organisers again for inviting me, at least, or us, to give the talks today. And let's hope that we can get prevention up and running again worldwide.
Thank you very much also for inviting me. Thank you.